my second topic was surgery for atrioventricular septal defect. I think almost everyone do not know where the Okayama is. We are the southwest of Japan, near Osaka and Kyoto. It takes 45 minutes by bullet train from Osaka, and 1 hour from Kyoto. The famous place, the Kumamoto, is here, where the big earthquake happened. And also 5 years ago, there's an earthquake, tsunami in Tohoku area in here. So Okayama is the most safest place in Japan. We have no volcanic band. Also, the Kobe is here. That's 100 miles away from Okayama. So everyone who is interested in Japan, you come to Okayama areas. It's the most safest place. We have the longest bridge between Mei Island and Shikoku Island, the South Island. The overall length is almost 30 kilos. Then a traditional Japanese castle, and also the local shogun's the garden, maybe a little bit bigger than the garden in UK and Europe. One of the three most famous local shogun's garden in Japan. The Okayama University was established in 1870, which is one of the oldest university in Japan. Compared to the Europe, it's not old at all. Our university have about 900 bed general university. Back to the AV septal defect. This slide shows the nomenclature of the septal defect by the International Paediatric and the Congenital Cardiac Code. The complete AV septal defect include an ostium defect of the atrial septum and non-restrictive defect in the inlet portion of the ventricular septum with one AV annulus and the common AV valve. This is the morphology of the AV valve is shown, and the view from the top. So the complete AV septal defect are characterized by complete absence of AV septum, also known as the endocardial cushion defect or the AV canal defect. And this accounts for 4 to 5% of congenital heart disease. And the last study described in 1966, a famous last study classification. Type A is the superior bridging leaflet attached to the crest of the interventricular septum, occurring in 50 or 70% of the patient. And the type B, I never see this one. The superior bridging leaflet is attached to the RV papillary muscle at the RV side of the interventricular septum, occurring 3%. We see sometimes an unbalance, but it's not like a two ventricular repair type AV septal defect. The type C is the superior bridging leaflet is free floating and is attached to the anterior papillary muscle, which is present at the apex of the right ventricle. This is quite often associated with the tetralogy of Fallot or DORB, and also very common in 21 trisomy, Down syndrome. So in Down syndrome, the complete form of AV septal defect is the most frequent type, and 70% of the children with a complete AV septal defect is Down. These patients have a greater degree of elevation of pulmonary vascular resistance in the first year of life, and a more rapid progression to fix the pulmonary vascular obstruction rather than without Down syndrome. The surgical correction should be carried out by even 3 months of age. On the surgical treatment in general, the repair should be done electively before 6 months of age. An earlier repair should be considered for infant with failure to thrive. For the symptomatic infant, surgical options include palliative pulmonary banding and complete repair of the anomaly. In the annual report of Japan, we have 168 patients who had a complete repair with 1 hospital death and 111 pulmonary banding with 1 hospital death. This is the actual data of Japan. So the rate of banding is quite high, I think, compared to Europe ESCTS or STS database. But note we have more than 100 unit pediatric cardiac surgical unit are doing just over 9,000 cases. So there's lots of units doing a very small number of cases. These units quite often do a band rather than complete repair in a small babies. So different surgical technique of the complete AV septal defect. The single patch technique in figure A, and the B is the 2-patch technique, and C is now the modified 1-patch. This is another view, the single patch and then the 2-patch, and recently the modified 1-patch become more common and popular. The single patch technique is more detailed, the illustration in here. There's a paper of the single patch technique, 119 patients and 3 operative deaths, mortality 2.5%, no operative deaths since 1995. The operation, 8 due to a significant left AV valve regurgitation, 1 due to LV outflow tract obstruction. The 2-patch technique is the most common technique in they reported no early death, and 2 patients died, and the 5-year survival was 97%. However, the overall 5-year freedom from reoperation after complete repair was 73.6%. And they concluded that the Down syndrome and the right ventricular dominant were independent predictor of reoperation in this article. Another paper from Leiden, more than 30 years experience with the surgical correction of AV septal defect. 312 patients, but the complete form is 209. And because of included the very early era, the mean age was 2.4 years, and 142 patients less than 6 months. Follow-up complete 99%, in hospital deaths and 8.3%, and late deaths 2.1. The estimate overall survival 91 in 1 year, and then 89% in 15 years, respectively. The freedom from reoperation for all hospital survivors and without any early reoperation was 81% at 15 years. The operation rate did not significantly differ between all groups, either complete or partial. There's another paper from the Pediatric Heart Network investigators. They have 120 patients, and the mean age is 3.7 months. The type of surgical repair, a single patch in 18 and double patch in 72%. And the incidence of residual septal defect and the degree of left AV valve regurgitation did differ by repair type. And in hospital mortality rate was 2.5%. Overall 6 months mortality was 4%. And the moderate or greater left AV valve regurgitation occurred in 22% at 6 months. So the new technique, a relatively new technique, is a modified single patch technique. The Graham Nunn in Sydney reported that the 47 patient with the repair of the AV, complete form of the AV septal defect with the modified single patch technique. The mortality is 4%, and mean age at repair 5.6 months, and no heart block, no significant residual VSD, and no LV outflow tract obstruction. Mitral regurgitation is more than moderate. It's 3 patients, 6% of the patient. The Ugaki reported the series from Edmonton and Canada. The 51 patient, median age 4 months, single patch 29, 2 patch 22, and they compare. They modified the single patch repair requires significant shorter bypass time, and also the shorter ischemic time than the 2 patch. And there's no hospital or late death during the follow-up time. The conclusion at the post-operative LV outflow tract diameter and the left AV valve leaflet coaptation lengths were not significantly different between 2 techniques. There's another paper from the ST's congenital heart surgery database, more than 2,000 cases and 101 centers, and 8% Down syndrome. The median age at surgery 4.6 months, and the median weight at surgery 5.0, and prominent banding applied 4.6%. The major complication occurs in 9.8%, including permanent pacemaker implantation in 2.7%. The median post-operative length stay, 8 days, overall hospital mortality 3, and the risk factor weight less than 3.5 kilos, and the age less than 2.5 months. The patient with Down syndrome had a lower rate of mortality and morbidity than other patients. So what about ours? We just compare the 2 patch repair and the modified 1 patch. In our initial series, we exclusively did a 2 patch technique and 110 patients and up to 2010. The median age at repair 6 months, the body weight 5.1, and 1 an operative death, 1 early death, and 1 1 more death. So the hospital mortality is 2. We have no rate of mortality. The survival is 98%. So the follow-up up to 16 years. The reoperation for left AV valve dysfunction is 10 and 9%, and 1 patient required a AV valve replacement. The reoperation for LV outward tract obstruction were 5%, and then 76% of the patient left AV valve regurgitation less than mild. So in the more recent series, 109 patients up to 200 from 1998 to 2014, Since 2006, we adopted the modified single patch and selected patient. So two-patch technique or modified single patch technique, and surgeon's preference and also the anatomies. The patient with unbalanced ventricle who were not suitable for biventricular repair or associated with the contract anomalies are excluded. Our surgical strategy is if the patient had the Down syndrome or the heart failure, we try to repair within 3 months. If not, then we electively repair less than 6 months of age. The indication of PA banding is body weight less than 2.5 or 3 kilos. They are associated with other complex cardiac anomalies, such as tetralogy fallow, DORB coarctation. The patient with platelet shock or other organ dysfunction, we do a PA banding. So the age of total repair, the median body weight, and etc., etc., the same, very much similar from our initial series. And the PA banding was applied in 16%, and the coarctation repair was done in 3 patients. Down syndrome found in 57%, and the left isomeres were in 6 patients. The lastly type A is 73%, and the lastly type C is 28%. So the double orifice AV valve, 2, a single papillary muscle, 5, a dysplastic leaflet in 6, and a small deficient left lateral leaflet found in 3 patients. For the procedures, a 2-patch repair, just over half of the patient, and the modified single patch, 1/3 of the patient. Recently, we applied more the modified single patch technique rather than 2-patch. This is just the surgical schema. With the modified single patch, we use autologous pericardium reinforced with ductum vellorum, ductum strip, or a Gore-Tex strip. So let me put I interrupted the matrix stitches to the VSD, which pass through the leaflet and reinforced with the Dacron or Gore-Tex the strip, and then pericardium, autologous pericardium patch. We do routinely close the cleft up to the edge. So compare 2 techniques. The VSD depth in 2-patch technique is deeper, because if it's a deep one, we quite often apply 2-patch. If it is lastly type A, even type C is a little bit narrower, and VSD we use a single patch, modified single patch technique. For the postoperative BNP is lower in the single patch technique, and also clock some time is much shorter and modified single patch. This is the 3-month-old, 4 kilos baby, the type A. As usual, from bypass, I usually cool down to 32 and give cardiopressure and rest. just test the coaptation. And put the stitch in the middle. I normally use a 6-fluorine. So you see this the type A. We put the projected mattress sutures to the crest, just the right side of the crest. This is a center where we divide the common leaflet. Quite often I miss it, so I draw before, not to miss the, not do any mistakes. And then this sutures pass through the autograph pericardium and also the small ductal strip or Gore-Tex strip. Then the closed cleft. And then test for the post-operative echo. This is a patient and the 4 months, 3.9 kilos, and the last study type C. Operation is very much the same of either the LASI type A or type C. This patient, the VC depth was only 6.8 millimeter, which is not huge. So I decided to do a modified one patch. So draw the picture before putting any stitches in a natural position. And put project the stitches, the same of the last day type A. So after repair, this. The median follow-up 4 years up to nearly 16 years. We lost 1, and the hospital mortality is a total 2, and no late deaths, and the overall survival was 98%. The RV-LV pressure ratio less than 0.4 was almost 90% of the patient. The operation is, as I said, 10. So since 2010, we have no reoperation or no deaths. The actual patient survival is 98, and the freedom from reoperation And five, as I said before, we have five patients who require the reoperation due to the airway outflow tract obstruction. So to compare in two different types of technique, redo and two-patch technique, and in the recent year, then we over 100 patients. We have 3 patients, but it's a modified one-patch, single patch, and no redo case so far. And also no LV outflow tract obstruction, reoperation for LV outflow reconstruction in a recent series, and then either a two-patch or modified one-patch technique. So in conclusion, that these results suggest that our strategy for complete AV receptor defect repair had a good midterm outcome in both techniques. A dysplastic leaflet and a small or deficient lateral leaflet and unbalanced AV receptor defect could be the significant risk factor for post-operative left AV valve failure and the required reoperation. Thank you very much.